All right. Got a full house out there. I thank everybody for sticking around. This is actually I think, a very interesting topic that we don't talk about enough, which is the management of groin wounds and what we can do to prevent infection, especially in patients with that are obese. So I'd like to start with a case. A 60-year-old female with a long history of claudication. She had been treated with medical management, smoking cessation, that type of thing, trying for weight loss. It eventually did progress to rest pain, and at an outside institution, they attempted to treat her endovascularly, but they weren't able to get through this big rock that was in her common femoral that you can see here. And so she was really sent to us for further evaluation, really wanted to see if there was another endovascular option for her. When I saw her, ABI was 0.35 on the right, 0.64 on the left, and really looking at the CAT scan, I thought she needed a right common femoral endarterectomy and external iliac angioplasty, probably extending the endarterectomy into the SFA. But here's the problem. You look at the CT scan, and as we're looking at the scout here, you can see that her femoral head is way above where her pannus sits, and so there's not a lot of space there. And so whenever you see this, it's always a concerning thing. And as I measured, just for this talk, the distance from the skin to the artery, it was 9 centimeters. And so that's going to be a pretty deep incision. And just to give more information, she was 5'4", weighed 212 pounds with a BMI of 36. So clearly this is that kind of patient where you look at it and say, I'm not really sure I want to go in this groin. So you have to really think about this, and I look at what are the options for closure in a patient like this. Well, there's the concept of the primary closure and hope, which I think a lot of us will do. You have an option of prophylactic muscle flaps, which we'll talk about, prophylactic vacs. And then there's newer options for things like the closed incision negative pressure therapy and antimicrobial dressings. So this looked at surgical site infections in 106 patients who had vascular procedures with a groin incision and primary closure. It's pretty contemporary data, and they had a 31% surgical site infection, which doubled the length of stay and led to a 50% reoperation rate. And then looking at, this is from a validated prediction model for groin infection. What they found that risk factors included obesity, redo groin, end-stage renal disease, being female, malnutrition, and urgent procedures. And so this patient has several choices from that, and this is what we're trying to avoid, right? So if you do a primary closure, and even if you keep them in the hospital for a week, when they eventually go home, the dressings are never good, and you're going to end up with some kind of big open wound like that, and we're really trying to avoid it. So Ben Franklin said an ounce of prevention is worth a pound of cure, and so when I see these patients now, I'm always trying to come up with something different that isn't just the traditional closure. So one of the options out there is a prophylactic muscle flap, and you can use different ones, but the sartorius is the one that I use. And what I tend to do is dissect the sartorius up to its origin there, and then once it's usually pretty avascular up there, and you can flip it on itself and sew it over the femoral vessels. Now, we clearly do that when there's infection, but this would be something we would do in the first time around, and then you would close over it. The idea there is if it starts to break down or you have problems, you at least have coverage over the artery, and so you're not going to get exposure. So this was a paper out of Philadelphia from Penn, and they had 68 patients with prophylactic muscle flaps versus 195 primary closures in patients that they considered high risk. With a similar risk factor profile where 30% of them were obese. And they found that in the prophylactic muscle flap, there was a much lower complication rate, 16% versus 50%. And the deep infection rate was significantly lower, of 1.5% versus 14%, although the length of stay was the same for both groups of patients, which was pretty long here when you're thinking 2 weeks in the length of stay. And they came up with a Penn groin assessment scale because, again, there are some downsides to doing this type of flap. The main one is that you've really created a situation where you're not going back in this groin again. And because once you've done a muscle flap, it's very difficult to dissect down. So if you have to re-intervene on a patient who has the risk factors, it can be a real problem. And so I think you want to make sure that you choose the right patient for this. And so they came up with this preoperative assessment, which they called the PGAS. And it was BMI greater than 30, gave you 2 points. Smoking history gave you 2 points. Prior groin surgery gave you 2 points. And then prosthetic reconstruction gave you 1. And so if you only had one risk factor, then for those patients, they consider them a low problem with a secondary flap need around 13%. And so they said no flap, just close them primarily. If you had 2 risk factors, then they want to do an intraoperative assessment and flap if you had a longer OR time or you felt that the wound was going to be high risk. And then the patients that have 3 risk factors or more, the chance of needing a secondary flap is almost 50%. And so those were the ones that they tend to do the prophylactic muscle flap. So I think it's actually a very reasonable way to do your decision making, and it really helps you to decide if you're going to do something that is this invasive. Now I have a former partner at MGH that also, when he would do this, would throw antibiotic beads in there as well, and I kind of look at that as a little bit of voodoo, but I never got into the beads, but I have done the flap. So another option is to do a prophylactic vac, and so the idea here is that you would close several layers of tissue and then put a vac on it. And there's some pros and cons to that. This is a small study where they did 9 prophylactic vacs. They closed the layers, placed the vac on top. They had a 0% infection rate in the group, and they felt that it decreased readmissions, and complications. And this is kind of what it looks like, and you can see this is the problem. When the pannus sits there, you can barely see the wound, and as you pull it back, you can see how difficult it would be to heal this without a vac. Now, the downfall here is if you think there's going to be a 50% breakdown, every one of these patients now has an open wound. So you go from a 50% open wound problem to 100%. And although you avoid the problem of it getting deep and exposing a graft, you are asking the patient to take 2 to 3 months to completely recover. And so I think it's something that you have to really discuss with them and to see what their ability is to manage something like this. So another option is the closed incision negative pressure, and this is an idea of closing the whole incision, and then you place a vac-like device, and now there are 3 that I'll talk about. Pros for that is this less invasive initial approach. It does remove the fluid and exudate and will protect the skin, and you can usually leave the vac in place for up to 7 days. The cons is that it can be difficult to keep in place in a very obese person. It doesn't always stick very well. And in some of them, if it malfunctions, then removal is the only option, and then you've burned that as an option, although I'll talk about one that you can actually replace it now. This is a systemic review and meta-analysis of 7 randomized control trials and 7 observational, so it's 4,130 groin wounds, and they found that doing the prophylactic closed incision negative pressure decreased your SSI rate, and the other thing they found was that doing a subcuticular closure also decreased the SSI rate, but this was found to be very effective, and when you're looking at this, it doesn't project well, but if you compare all the studies in the group, using the closed suction was very favorable for preventing infection, and if you just look at the randomized control trials, that too favored it, but when you looked at the observational studies, it was a little bit going towards both sides, so that wasn't significant. And so here are some of our options. That picture on the left is essentially a traditional vac dressing with a skin sponge that's in place, and you can see that the vac comes off, so you have the full canister. That's good, especially if you have a lymph leak or you're going to have high volume of drainage, and that can be changed every couple of days, and so that can certainly be an option. And then you've got the Prevene on the other side here. That has it's a closed suction group as well. The suction lasts for 7 days. You can leave it on for up to that amount of time. Downfall here is if it doesn't stick or you lose suction or have a problem, then it's done. You got to throw it away and open another one, and so it can really burn your bridges. The Vel is newer to the market, but it has some real advantages in that in this closed suction, the actual battery lasts for 30 days. So you can actually use this for a much longer time, and it seems more appropriate at getting to heal. And then you're able to actually switch out the pads. So you can do dressing changes with this on a regular basis and still use the same box. And so I think it does decrease the cost. And the idea here is that basically you get fluid transmission. The negative pressure will pull the fluid up, and then it actually evaporates through the dressing. So that's why you don't need a canister. So any of the moisture you would have there would evaporate through as it pulls it up. And then they've got this multiple ply parts to the dressing that helps to wick the water up or wick any fluid up, and then helps it to evaporate off. So I think it's an interesting technology, and again, one of the big benefits here is that you can do frequent dressing changes and use the same pump, and there's no canister. And that's it again. So the last thing is the antimicrobial dressings. The Aquacel AG is the one that I like to use. It acts as a barrier to pathogen transmission. It has the antimicrobial effect of silver, and it can be left on for 7 days. So I wouldn't necessarily use this in someone with a BMI of 36, but if you get somebody who's maybe a little more portly, they're not the skinniest person, this is a really great way to bridge the dressing so you can put it on, not touch it for 7 days. The cons is that it's been used on other things, but there's really anecdotal experience in groins, and it, again, may be hard to keep in place. But essentially, what you've got here is a couple aspects to it. It locks in the exudate and traps out bacteria. It has micro contours to the wound bed, so it really sits down nicely. And then it can respond to fluid levels by forming a cohesive gel. And by those three things together really help to help the wound to heal. And this is just a patient with a couple of them on there, a big wound, and you can see that they give you a nice seal and a nice dressing. So in conclusion, groin incisions in obese patients are tough to heal. You need to consider adjuncts beyond primary closure. The less invasive options, such as antimicrobial dressings and the closed pumps, do show promise, but we still need close follow-up in these patients to avoid the catastrophic complications. Thank you.
All right, well, thanks, Mark. And so we'll close this out, basically switching gears and talking about now what happens. So you did everything you wanted to do correctly, and somehow you still ended up with an open groin wound. And similar, very, I think, fitting to Dr. Lee's talk about Achilles heel. This one probably represents one of what we do, the Achilles heel of a lot of the lower extremity work. So disclosures for this talk. So the risk factor for groin wound complications really boil down to, it's a pretty high rate, 10 to 44%, and they add significant cost, which is a big driver these days, but also morbidity and mortality. If you've ever had to handle a groin wound, a groin blowout, it's very exciting and something you want to avoid. So when you look at the papers, risk factors: female, obesity, urgent procedure, reoperative groin, a long longitudinal incision across the groin crease, age, malnutrition, which actually is a huge one, and end-stage renal disease. And a lot of people have looked and tried to make validated predictive models, and you saw one of the ones from the Penn group about whether to use prophylactic flaps, and other people have validated studies. This one looked at 254 patients, and they split the group into two, and they looked at a bunch of different factors, and really they came up with basically a lot of the same factors. So there's the female age and the malnutrition, urgent nature of the procedure, but you'll see that malnutrition probably has the highest odds ratio there of a potential wound complication. So before we go any further, there is a classification system, the Siglagli classification system, and it's useful to help kind of define what you're talking about. So the stage 1, basically on the left here, shows just either skin necrosis or just a superficial wound breakdown. What we're really concerned about here is stage 2 and stage 3, where you're getting opening of the wound into the deeper layers of the tissue, and then stage 3, where you have exposed vascular structures or prosthetic graft. So the two wounds, this is dehiscence of the skin, possibly the deeper layer, but again, your vessels are still covered.
and obviously represents the better of the two scenarios. So here was a case of mine, which is a 75-year-old obese female, common femoral endarterectomy, bovine pericardial patch. The incision, as you can see, is longitudinal and crossed the groin crease because I did have to do part of the SFA. So that, again, she's obese, she's female, she already meets, 3 of the criteria. Of course, she missed her first post-operative appointment and then ended up in the clinic a month later with this. So what's the treatment algorithm here? Well, I think, since we're surgeons, obviously, if you need to operatively debride it, then you'd have to do that. And obviously, consider antibiotics if you think there's an underlying cellulitis or something that needs to be treated. I don't use antibiotics routinely if the wound actually looks fairly clean and it's just a wound breakdown. Obviously, you want to correct all the underlying disorders that you can correct, and the biggest one being malnutrition, and a lot of our patients just don't eat well once they leave the hospital. But I think that most would agree that the standard here is negative pressure wound therapy, so the VAC dressing. And essentially what it does is, as Mark described, it wicks away the fluid, it creates a moist wound bed to help promote wound healing. And then with nutritional optimization, it really, with the negative pressure, builds vessels and tissue upward, fills the wounds in very, very quickly. And you can see a table to the left, to the right, that basically details a lot of these positive features for the VAC. And I think most of us tend to use it routinely in wounds where we're not seeing vascular grafts. And if you look at this paper out of Buffalo, they looked at 22 patients, and of these they had 11 that were the stage 2 classification. And basically the highlights of the paper is they actually got all the wounds to heal, but their only failures were in stage 3, which we'll talk about, but all their stage 2 wounds healed. And so for this particular patient, the result was good, and that's what I did. We did not need to operatively debride because the wound was clean. I did stress the importance of good nutrition, and then we applied the negative pressure dressing. It takes a while. It was 3 times per week changes for about 3 weeks before we got it to fill in fairly nicely. And I see these patients weekly when this goes down, because at any point, if it starts to turn south, you need to get on it quickly because it can really degenerate for you. And we let this one close secondarily. So stage 3 wounds are the ones that really give me a lot of grief. Now you've got exposed vascular structures, and worse yet, exposed prosthetic graft, and obviously the worst of the two scenarios. I think it represents a pretty complex scenario, and we're going to go over some of the options here, some of which were already touched on previously. So 80-year-old obese female, FEM-TPT bypass, PTFE, no conduit for gangrene, longitudinal incision, and despite her obesity, she was relatively malnourished, low prealbumin levels. First postoperative visit at 2 weeks, she had some serous drainage. So usually you're going to say, okay, I'm going to try to salvage this out. Hopefully it's just something that she's going to heal on her own. But a week later, the patient presented with the wound dehiscence, and you can't really make it out from the picture, but if you poke right in the middle of that wound, you go right down to the graft. So it's basically, had that sinking feeling and knew that we were going to be in for the long haul here. So it was touched on briefly. So basically, groin wound coverage, I think that, a lot of people would kind of go this route, and this is probably my first line therapy, which is to basically get some healthy tissue over the graft. Groin wound muscle flaps work very well, and the reference to the paper at Penn also is one that I'm referencing here as well, where you can have very good success rates, and a lot of the decision making is in conjunction with your plastic surgeon looking at the various targets for the use. And they have a nice diagram here where they talk about the different types of muscle flaps. So the sartorius, which is probably the easiest to harvest, but if your SFA is out, they may not have good blood supply, so then you may think to use the gracilis or the rectus femoris muscle flap for the coverage. Now this provides a very good vascular bed, which then means if you're delivering antibiotics, it'll also get down to the graft. And as long as they're nutritionally optimized and the graft sits well, it will usually incorporate into prosthetic graft work that you have underlying underneath. Another paper out of China also detailed a similar kind of protocol. They utilized 2 other additional flaps, the ALT flap on the side, as well as another flap that I've actually never really heard or used of in the US, but they have an algorithm as well. And it all boils down to the size of the wound and where the wound sits and whether you have exposed vascular structures for the amount of healthiness of that. Now, I think it's important to note that the timing of the coverage matters significantly, so you do not want to delay on these. And so if you are suspecting this is the case, you need to watch these patients closely. And the minute you think that it's going to go bad, you need to have that discussion, both with the patient and your plastic surgeon if you're having them help you out, because the salvageability of these, especially when they're vascular structures underneath, is significantly better, as you can see from the graph on the right, if you get to it early. And if you miss the window, it degenerates pretty quickly from there. Another option, though, that's kind of come out, and this was the same paper I presented earlier, is some people have been exploring the use of wound vacs directly on suture lines, exposed vascular structures, and prosthetic graft work. And while it's a small study, of the 12 patients they had in the class 3 category in this study, they did get about over 80% to heal, so a 17% failure rate. Only thing about it is, while the numbers look pretty good, if it fails, it's usually a pretty disastrous situation. So it's the only drawback, because if they blow out and start bleeding, then it's a urgent rush to the operating room. So just keep that in mind. But I think that if you have somebody without great options, you can try to salvage this out with just vac dressing alone. So the patient 2 results were good. We did antibiotics, washed out, debrided in the operating room. I had plastic surgery come and perform a rectus femoris muscle flap. That's a flap that I cannot do myself, or I don't know how to do myself. And then we did negative pressure until there was a granulation base. And then they came back, well, actually I came back and skin grafted this patient. So I think it's important then to think, well, we don't never want to get to this point. And some of these were touched upon by Dr. Conrad, but essentially same concept applies. You want to prevent groin wound breakdown at all costs. So what's the ideal dressing here? Keep the wound protected, wick fluid away, antimicrobial, low maintenance, cost effective. That's actually quite important these days. And so there are a number of options here. The Aquacel surgical dressing, which is silver dressing, which I do use, and then a number of incisional skin vacs. So I think that, again, reiterating some of the previous messages, this dressing I like because of the antimicrobial nature, and it basically will wick away fluid. It's pretty low maintenance because you can keep it on for up to 7 days, although I watch it, and if it starts getting saturated, I'll usually take it off because then, it's really lost that element of it. And from a cost-effective standpoint, it's cost-effective, so that's important to me. Patients like it because of the barrier. It's waterproof, so you can essentially just shower over it, and that leads to a lot of immediate satisfaction. Studies so far have mostly been in the orthopedic literature. Hopefully, perhaps there will be some vascular studies in the future. And so again, it's got the silver ions, and then there's a newer version called this Aquacel Silver Advantage that has a chelator that can help with the ion delivery as well. And the dressing's absorbent nature I find to be very good. And so I think in that stance, it is unique relative to the other products that have silver on the market. So I do use it, and this was a redo groin. I did not use the subcuticular. I did it with vertical mattress nylon sutures. And again, incisional vac therapy I think is important, and I won't belabor this point, but I think that preventing class 2 and class 3 Siglagi groin wound complications, this paper shows that the incisional vac will do that, and so those are the ones you obviously want to prevent overall, and it has a lot of the same features of the silver Aquacel dressing. It's just more expensive, so you do have to keep that in mind. The Avel, which was mentioned before, however, is cheaper, so that is a positive when you're kind of going to your hospital and asking for the newer technologies. So I think in summary, appropriate incision dressings that can wick away the drainage, control the moisture, prevent wound breakdown in high-risk patients is important and can really mitigate some of these issues. The negative pressure wound vac, incisional wound vac, or regular wound vac can allow salvage of these open groin wounds and really will build tissues. Can even use it in exposed graft. However, I have a low threshold to utilize muscle flaps if I suspect any compromised graft, and especially if it's infected, or I think it's infected grossly in bacteria such as Pseudomonas. It's a muscle flap all the way. But once the granulation bed is built, I do use dressings such as the Aquacel Silver that just can absorb dressing while the wound is kind of waiting the appropriate depth before I can get it closed formally. So thank you very much.